Hi, I'm Dr. Christina Wu. I'm Associate Professor at Emory University Winship Cancer Institute. I am a GI medical oncologist. Generally, I do consider colon and rectal cancer similar in a metastatic setting when we're thinking about staging. Um, CT scans of the chest, abdomen, pelvis are usually good to start with in terms of finding metastatic disease. If there are any questionable lesions in the liver, for example, then we would do an MRI liver at that point to get better characterization. If there is an area in question, we may add a PET CT scan. But these are when we have found a specific lesion that we would like to work up. But when we think about early stage colon cancer and early stage rectal cancer, I actually think staging are fairly different, and we have to think of them this way. For colon cancer, when an early stage colon cancer, when there is a new diagnosis, often it is made when patients have had either a screening or diagnostic colonoscopy or found due to symptoms on a CT scan where there may be an apical lesion or bowel thickening. And so from an early stage colon cancer, we do CT chest abdomen to rule out metastatic disease, and that should be adequate. For early stage rectal cancer, it's fairly different. When we want to look for metastatic disease, we order CT chest and abdomen. But when it comes to looking at the primary tumor itself, now the standard really is looking at an MRI pelvis with the rectal cancer protocol. The importance of that is we want to look at the rectal tumor itself and to know the TNM staging. And it's really the rectal MRI that's allowing us to know the T1 through T4 staging and nodal possibility. In addition, we're going to be able to know if it's above or below the peritoneal reflection to confirm a rectosigmoid versus a high rectal cancer. And we'll also have a better idea of where it is from the sphincter, anal sphincter. Now, this does not mean we don't do a proctoscopy or flex sig, where we're going to take a look and know exactly the distance of the rectal tumor from the anal sphincter. But an MRI pelvis is very essential, I believe, in staging a rectal tumor. If there are contraindications to an MRI, that's when we think about an endoscopic with ultrasound, so we can do the staging that way. But really, we are now looking at MRI pelvis for our rectal cancer patients. And so that's why I do think of them as two separate entities when we're looking at early stage colon and rectal cancer. The next question is, are there any features that we look at beyond staging in colon and rectal cancer? And I'll start with colon cancer first. For colon cancer, we always have to look, for staging to see if the patient has stage 1, 2, 3. And the big difference between the stage 2 and 3 is lymph nodes. And that is where staging is extremely important. Other things that we want to look at the pathology report are high-risk features that may prompt us to discuss adjuvant therapy in the stage 2 setting when there are no lymph nodes that are positive for cancer. The first thing I look at is that adequate lymph nodes were taken. Right now, the standard is 12 or more lymph nodes have to be retrieved and identified. If there are less than 12 lymph nodes, that does make me think about talking to a patient about higher risk and thinking about adjuvant chemotherapy. Other things are presence of lymphovascular invasion or perineural invasion. The presence can also hint towards high risk. And finally, positive and negative margins. In addition, for colon cancer, we also look at the presence or absence of CDX2 staining. There was a trial in patients who lacked CDX2 and seemed to benefit more from adjuvant chemotherapy as well. And most importantly, in the stage 2 setting, we look for the presence or lack of mismatch repair proteins, because in a large study, a retrospective study looking at stage 2 patients who received adjuvant 5FU therapy, patient with mismatch repair proteins not only did not benefit from the adjuvant 5FU, but it had better prognosis. So on the whole, these are all the different characteristics and things that I look at in a pathology report when I'm thinking about whether I want to offer a patient with stage 2 cancer adjuvant chemotherapy. In addition, when we're thinking about staging in stage 2, T4 is actually very important as well. It does lend towards a higher risk of recurrence, and those are where the conversations are also had about adjuvant chemotherapy.